Usually when we think about healing from surgery, we picture it like repairing a massive suspension bridge.
Right, like an engineering project.
Yeah, exactly. You replace the snapped cables, you bolt the steel back into place, and you just expect the tension to be perfectly balanced again. Nice, even, completely symmetrical.
We really want to believe that the body acts like this highly obedient construction crew. Like it's just following the architectural blueprints to the letter.
Prioritizing perfect equilibrium.
Exactly. But, well, then you look at what actually happens in the human body,
Right.
especially in highly sensitive, complex areas, and suddenly you realize that construction crew is completely unsupervised.
They're just doing whatever they want. One side of the bridge is pulled way too tight, the other is, like, rigid, and the whole structure is thrown completely off balance.
It is the absolute definition of physiological chaos. I mean, the body's healing process is incredibly robust, but it prioritizes sheer speed and wound closure far, far above any kind of structural symmetry.
Which brings us to today. Welcome to today's custom-tailored deep dive. If you're listening to this, you are someone who loves to learn. You want the thorough, efficient shortcut to those big aha moments, but, without getting bogged down in the dense medical jargon.
And today's topic is definitely one that needs unpacking.
It really is. Today we have a highly specific but just incredibly critical medical question to explore, and that is, how is uneven tightness managed after surgery?
Yeah, we are looking at a very specific set of circumstances here. We're talking about the aftermath of pelvic surgeries, gynecological procedures, gender-affirming surgeries, and even the aftermath of radiation therapy and childbirth.
We've got a fantastic stack of sources to guide us today, too. We're drawing heavily from current clinical guidelines from IBIQ, patient information leaflets from several NHS trusts, and some really detailed expert FAQs from Women's Health Clinic.
It's a great mix of practical and clinical insights.
Okay, let's unpack this. We are going to decode exactly how medical professionals tackle post-operative scarring and stenosis. We'll trace the roadmap all the way from conservative at-home therapies right up to surgical interventions.
But before we get into the how-to of fixing it, we really need to understand what it actually is on a cellular level.
Right, like what is literally happening when tissue heals unevenly?
Well, we are looking at a fundamental shift in the cellular matrix. Since you follow the clinical side of this, you already know we were dealing with stenosis.
Which is, just for clarity, the rigid narrowing and shortening of the vaginal canal. Right.
Yeah.
Usually accompanied by dense scar tissue and dryness.
Exactly. What's fascinating here is distinguishing the underlying pathology of that stenosis from healthy tightness or, simple vaginal laxity.
Because they aren't the same thing at all.
Not at all. Mechanically, they present in entirely different ways.
The sources make a really hard line on that distinction. I mean, laxity is usually about the pelvic floor muscles losing their tone, which gives a sensation of looseness. But stenosis is a physical reduction in capacity.
The tissue actually changes. It loses its natural flexibility, it becomes unyielding, and most importantly, it causes active pain.
So what causes that tissue change in the first place?
To understand the loss of elasticity, we really have to look at the triggers. Pelvic surgery, hysterectomies, perineal tearing from childbirth, and drops in estrogen from menopause or breast cancer treatments all play a part.
But the clinical guidelines call out radiation therapy as one of the biggest culprits, right?
Yeah, radiation for pelvic cancers is one of the most aggressive triggers because it fundamentally alters the local environment. I mean, a scalpel makes a clean physical cut, but radiation actually damages the DNA of the cells.
So it doesn't just sever the tissue, it changes the whole biological neighborhood.
Exactly. And the progression of that specific tissue damage is really interesting. Radiation injury happens in distinct biological phases.
Like an acute and a chronic phase.
Right. First, you have the acute phase, which is immediate mucosal inflammation. The tissue is just red, angry, and inflamed. But as that acute phase subsides, you enter the chronic phase, which is driven by endarteritis.
Endarteritis, that's the inflammation of the inner lining of your arteries, right?
And that inflammation basically chokes off the blood supply.
Wow.
So the chronic phase brings these severe ischemic changes, meaning a lack of oxygenated blood flow. The body responds to this low oxygen environment by dropping down fibrotic tissue.
Just trying to stabilize things.
Exactly. It leads to what is clinically called circumferential fibrosis. The tissue literally forms rigid, constricting bands all the way around the canal.
And if you are dealing with this, it severely impacts your quality of life. I mean, routine medical exams become excruciating, sexual intercourse can become impossible, and in severe cases, the canal can become entirely obstructed.
It's a profound structural change.
It makes me think of, like, imagine a tear in a really comfortable, stretchy pair of sweatpants. If you rip the knee and you sew it back up rapidly, using really thick, rigid thread instead of normal thread, that one spot becomes this tight, unyielding knot.
That is a perfect analogy.
The rest of the fabric is still stretchy, but that one rigid knot pulls everything out of alignment and makes the whole leg feel tight.
That is exactly what is happening with collagen. When human tissue is injured, the body's primary objective is to close the wound immediately to prevent infection. So it rapidly produces this structural protein called collagen.
But because the biological construction crew is essentially panicking, they don't lay those collagen fibers down in a neat, organized way.
Right, they don't mimic the original tissue at all. They just throw them down haphazardly to plug the hole.
Like dropping a pile of sticks on the ground instead of weaving a flexible basket.
Exactly. The fibers cross over each other randomly, and the resulting scar is firm, raised, uneven, and biologically just far less stretchy than the healthy tissue around it.
And it's that disorganized, rigid collagen that makes the area feel excessively tight and sensitive.
Yes, it pulls the surrounding anatomy completely out of its normal alignment.
Which brings us to the obvious question. Once you have that tight, disorganized knot of collagen, how on earth do you manage it? How do you manually break down that rigid thread?
Well, according to the guidelines from various NHS trusts, the first line of defense is actually incredibly hands-on.
Targeted scar mobilization, right? Like scar massage.
Yes, but timing is the absolute golden rule here.
Right.
If you are navigating this recovery, you must wait until the wound is fully healed.
So no rushing the process.
None. For perineal tears from childbirth or pelvic surgery, that usually means waiting at least 6 to 8 weeks.
Okay, so the stitches must be completely dissolved.
Exactly. The skin barrier must be intact with 0 signs of infection. Now, for some gender-affirming surgeries, the timeline can occasionally be shorter, around 3 weeks post-op, but strictly only with your surgeon's direct approval.
Wait, isn't applying physical pressure to a relatively fresh healing surgical site totally counterintuitive? Doesn't that risk just reopening the wound you just spent weeks healing?
I mean, it seems counterintuitive until you look at the actual goals of the tissue remodeling phase. That's exactly why the wait until fully closed rule is so rigid.
Ah, because once it's closed, the goal changes.
Right. Once the skin barrier is secure, your goal shifts from closing the wound to reorganizing the tissue. When you apply targeted massage, you are physically manipulating those crossed over collagen fibers.
You're forcing them to realign.
Yes. You generate mechanical signals that tell the local cells to restructure that lattice. And simultaneously, you are forcing increased local blood flow into that tight area.
And that fresh blood flow is doing a lot of the heavy lifting, I imagine.
It is. Increased blood flow literally raises the temperature of the scar tissue. That local warmth makes the existing collagen more pliable. It basically warms up the tissue so those random sticks can break down or regain elasticity.
You're warming up the thick thread to make it bend. And the clinical leaflets are really specific about the tools you use for this massage. They recommend natural lubricants like almond oil, olive oil, coconut oil, or, for external scars, medical-grade silicone sheets and gels.
Silicone is particularly effective on a cellular level. It doesn't just lubricate, it actually hydrates the tissue and helps regulate collagen production.
It tells the body to stop overproducing the scar tissue.
Yes, it sends a biological feedback signal to downregulate the collagen. It helps flatten and soften raised scars over the course of several months.
So if you're the one having to do this massage at home, how do you actually do it? Because the NHS guidelines prescribe highly specific motions. You don't just rub it randomly.
No, technique is very important.
They want you using your fingertips in circular motions over the scar, then moving up and down vertically, then side to side horizontally.
And they also detail a specific technique known as scar rolling. So if you were performing this on the perineum, you would place your thumb just inside the vaginal opening.
Okay, and where does the index finger go?
Your index finger goes on the outside, on the perineum. You then gently massage the tissue between your fingers in a circular movement.
Almost like you're rolling a small ball between your finger.
Exactly like that. It isolates the scar tissue and breaks down adhesions between the skin and the underlying layers.
And to address the uneven part of the tightness, if you find one particular spot or direction feels way tighter than the rest, the instructions say to hold a gentle stretch in that specific direction.
Right. You hold it for up to 90 seconds.
90 seconds seems like a long time to hold a stretch.
It can be, but you hold it until you literally feel the tension physically begin to ease. There's also another specific technique where you make firm U shapes along the bottom of the vaginal opening.
Like moving between 4 and 8 on a clock face.
Exactly. And this highlights a crucial principle. It isn't about applying aggressive force. It's about persistent, gentle pressure that signals the tissue to lengthen without panicking and creating more inflammation.
Right. But manual massage really only addresses the external scars, like the perineum. What happens when the tightness and the stenosis are deep inside, like after pelvic radiation? You can't just reach deep in there and massage a rigid band of fibrosis.
No, you can't. In those cases, the management strategy shifts from external manual massage to internal management.
Using vaginal dilators.
Yes, dilator therapy is the gold standard for that deep internal tightness.
According to the sources, a dilator is basically a smooth tube, usually made of plastic or medical-grade silicone.
And they come in progressive sizes, right?
There they do. They start from something the size of a slim finger or a tampon, all the way up to the size of a large erection.
And if you're using this therapy after radiation, the protocol from the EVQ guidelines is very structured. You generally start around 4 weeks post-radiation.
Right, you have to wait until that acute angry inflammation has entirely resolved.
Then you use a water-based lubricant, and you leave the dilator in place for anywhere from 1 to 10 minutes.
Systematically increasing the size as the tissue allows, yes. Here's where it gets really interesting. When you first hear about dilators, you assume it's purely a mechanical process, like, stretching a tight hamstring. You put the tube in, it physically pushes against the scar tissue, breaks down the internal adhesions, and just mechanically holds the space open.
And that mechanical stretching is a vital component. It applies radial pressure that prevents the walls of the vagina from adhering to each other.
But the clinical literature from the psychosexual therapy teams emphasizes that it is so much more than just a physical stretch. It is active neuromuscular retraining.
Absolutely. The nervous system plays a massive role here.
It's teaching tissues that have become super oversensitive to touch that normal physical contact is actually safe. It's not just stretching, it's retraining the pelvic floor muscles to relax and lengthen.
Exactly.
It sounds like, well, imagine you have a rescue dog that has been traumatized. If you just reach out and grab the dog, it's going to bite you or cower and tense up in defense.
Right, it goes into fight or flight.
Exactly. You have to slowly, gently offer your hand over and over again to teach the dog's nervous system that your touch doesn't mean pain. Using a dilator isn't just forcing a muscle open. You are teaching a frightened, traumatized pelvic floor that it is safe to let go.
I love that analogy because it validates the profound psychological component highlighted in the sources. Our minds and bodies are inextricably linked.
Tension in the mind causes the body to tense up.
Yes. The clinical leaflets make it clear that if you are doing this therapy, you cannot be rushed. You are explicitly advised to practice deep breathing and mental relaxation.
So relaxation is actually a physical medical requirement for this therapy to work?
It is. If your mind perceives a threat, your sympathetic nervous system kicks in, and your pelvic floor will automatically clamp down in a protective reflex. If you try to force the therapy then, you'll cause micro-tearing and actively worsen the stenosis.
Wow. And what does the broader medical evidence say about how well this actually works? Because we have a Cochrane review in our stack today.
We do. And Cochrane reviews synthesize all available high-quality data. They look specifically at dilator therapy for women after pelvic radiotherapy.
And what did they find in the data?
Well, they found a significant methodological hurdle. Randomized controlled trials, which are the gold standard of medical studies, are incredibly difficult, if not ethically impossible, to conduct in this area.
Right, because to do a proper trial, you'd have to ask one group of women to use a dilator and instruct a control group to completely avoid any intervention.
Knowing full well the permanent consequences.
Nobody wants to be assigned to the placebo group if it means their anatomy might permanently scar shut.
Exactly. The ethical constraints are massive. Therefore, the review relies on observational studies. But those studies show a very strong, consistent association-frequent dilator practice is consistently linked to lower rates of self-reported stenosis.
So the regular practice really does maintain the capacity and keep the canal open.
Yes, which is non-negotiable for ensuring doctors can perform ongoing, life-saving cancer follow-up exams.
So, if you're navigating this, you have your first line of defense. You respect the body's collagen response, wait for the wound to close, and use manual massage to break down the external scars. Then you use dilators and deep breathing to neurologically retrain the internal muscles.
Right, you remodel the tissue conservatively.
But what happens when you do all of that diligently and it simply isn't enough to overcome a severe stricture?
That brings us to the final tool in the clinical toolkit. When conservative measures fail, and you are left with an unyielding stricture or a painful skin web, surgeons turn to surgical revision.
The surgical reset.
Yes,
The sources refer to this under a few different names, right? Fenton's procedure, perineal revision, or perineoplasty.
correct. It involves the surgical excision, the physical removal of that stubborn scar tissue or area of constriction right around the perineum.
So the surgeon just cuts away the inflexible tissue and reshapes the area by trimming and stitching healthy tissue back together.
Yes, without the tension. It's usually a quick procedure, taking about an hour.
Now, the Cleveland Clinic source makes a really important distinction here. A perineoplasty is not a vaginoplasty.
No, it is not. A vaginoplasty is a complex surgery involving the deep internal vaginal canal. A perineoplasty does not alter the internal architecture at all. It only restores function and tightness to the muscles at the external opening.
Okay, got it. And recovery takes about 6 to 8 weeks, during which you have to avoid sex, bikes, heavy lifting, all of that.
Yes. But there is a major risk to note with this procedure.
Which is?
If the Fenton's procedure fails to heal perfectly, it can actually cause significantly more scar tissue to develop than was there in the first place.
Oh, wow. Especially in patients who are naturally prone to scarring.
Exactly.
So here's my big logistical question for you. If this surgery only takes an hour and it directly cuts out the problem tissue, why do doctors make patients try months of daily massages and dilators first? Why not just do the surgery right away?
If we connect this to the bigger picture of how the body handles trauma, the danger becomes very clear. Anytime a scalpel cuts into human tissue, you are creating a brand new wound.
And what does the biological construction crew do with the new wound? It panics and drops another load of chaotic collagen sticks.
Precisely. And that risk is magnified exponentially if your tissue was previously treated with radiation. Surgery on irradiated tissue carries a notoriously high risk of delayed wound healing and creating massive new scars.
So conservative management is just always the safest first step before cutting.
It absolutely is. You have to exhaust all conservative options first.
Okay, that makes perfect sense. So let's synthesize this whole journey. When it comes to managing uneven tightness after surgery, medical science manages it by starting with respecting the body's overzealous collagen response.
You have to wait for it to heal.
Right. Then moving to manual manipulation, using targeted massage and dilators to remodel the tissue, and only using surgical revision like Fenton's procedure as a final tool to reshape the anatomy if all else fails.
Exactly. It's a very logical, stepwise progression.
So what does this all mean for you?
Well, the sources heavily emphasize that for dilator therapy to work, the patient must practice deep breathing, address their emotions, and avoid getting caught up with anxious thoughts.
Right, because of that neurological link.
Exactly. It reveals this really profound truth about human anatomy, that our psychology is so deeply woven into our physiology that an anxious thought can literally manifest as a physical muscular stricture.
The mind and the body are just one continuous loop.
They are. And it really begs the question, how many other physical ailments in our bodies are actually just trapped tension that we haven't yet learned how to mentally release?
That is something to think about.